Welcome to PCR 2017 in Paris. I'm happy to be here with Hendrik Treade, cardiac surgeon from Halle in Germany, and Professor Vahanian from Hospital Bichat in Paris. Great to have you here. And a burning topic is valve and valve and valve and ring, and that's what we're going to discuss. Alec, could you give a little bit perspective of which patient would qualify for a mitral valve prosthesis?
For mitral valve prosthesis, it's not written in the guideline. So difficult to give an answer, but what we can see from the experience in something published in 500 cases is probably the patient who are inoperable or extremely high risk for surgery who deserve a treatment because of stenosis, regurg or both. That's the group we should target today.
Right. And the valve and ring, how many patients are there?
I cannot tell you. I think it's a sort of split, maybe less patients than valve in valve. It's probably a slightly different population because here we may add to the dysfunction of the ring, dysfunction of the LV, and many more comorbidities. So it's a slightly worse population.
Right. So which patients would qualify for it? What type of disease?
For valve in ring, I think we have to treat patients who are not, at the too late stage, of course, terrible ventricle, too many comorbidities, but we have also to take into account anatomic conditions, that is to say, but maybe Hendrik wants to ask, because I'm not a surgeon.
Yeah, Hendrik, so when does a surgical valve repair fail that you say, well, we cannot reoperate, but we should give a valve in a ring?
Yeah, I think first of all it's about functional MR, because we know that these rings implanted are somehow failing depending on the condition the patient had when he went into the operation room. And if you already have a large ventricle, if you already have a small tenting height, then the recurrence rate of MR after surgical repair is pretty high. Right. And those might be patients who might qualify for a valve and ring procedure afterwards because they might be still too sick to undergo a reoperation surgery.
Yeah. But so do you think we can even prolong the life expectancy if we do this type of procedure?
I don't think that the life expectancy is so much influenced by this procedure. The risk of the procedure should be low, of course. That if we take out the procedural risk alone, then life expectancy is more depending on other co-founding factors like ventricular function, like comorbidities in these very sick patients.
Right, right. And so what kind of access route would you choose?
Yeah, well, for most of them we have used the transapical access. But of course this is a different animal. It's not aortic stenosis, it's not hypertrophic ventricles, so it's very weak ventricles. So more and more people now try to implant the valve transseptally. What is doable? Well, it's a bit more cumbersome, I think, but maybe this is the way to go.
Alec, do you agree?
Yes, because I think we did one of the first transseptal. I think it's much easier all in all, and probably harms less the patient, because in her case, this patient, they don't even go to the ICU. Right. They are extubated on the table and they come back to their ward after a couple of hours. So it's much easier, but as you said very correctly, you need to spot your transseptal, then you need a couple of tricks to do that, but it is doable, especially in valve in valve. Right. Valve in ring, it's a little bit more difficult, but very easily doable with some experience. I think you'll be moving to this
yes,
procedure.
Definitely. We already did.
Yeah. So how many centers should do this type of procedures? If it's so rare, do you have any recommendation here?
It's difficult for me to say in France, but I think grossly probably over 10 are doing this procedure in France.
Okay.
Today.
But it should be in a specialized center.
Exactly, the valve centers.
Yeah.
The valve centers. Those who do TAVI, who do mitral clip, who do all these sort of procedures. Should be expert centers.
So another type of disease is tricuspid insufficiency, which can have a great morbidity and also mortality for patients. Is there any option then for a transcatheter heart valve in a tricuspid ring or even in a native tricuspid insufficiency?
Well, in native we don't have anything yet, but there are devices being developed right now, and it's very interesting to see how they perform, but there's not much data out. There was a report on first two patients implanted with transcatheter tricuspid valves, but this is very early experience, so I think it's not worth going too deep into it at this time point. But of course, ring implantation is a standard method, and there are also now rings taken from the mitral side, more or less, being implemented for the tricuspid side. If that then becomes at a certain stage a patient that would take profit from a valve and ring, it's hard to say right now. The surgical rings we use right now for tricuspid repair are not so well suited for a valve and ring because they are open. They have to be open for the sparing of the AV node, and that makes them not good candidates actually for such a procedure.
Yeah. So talking about candidates, Alec, because those patients are very sick, that come with tricuspid insufficiency, that you need to treat them, especially when they have a ring, that means a reoperation. So how many patients do you think that you could see per year with this type of disease?
Quite few.
Yeah.
Well, less than one a month in our experience, even if we have a relatively large valve centers, because I think you have to go stepwise, and we discussed that before. In aortic, it's not always easy to say when it is futile. Yeah. In mitral, it's even more difficult, but I guess in tricuspid, it is more and more difficult because comorbidities, left ventricle, left valves, right ventricle, so many things add on before deciding to do something on the valve.
Right. And so if you think about the native tricuspid insufficiency, the isolated ones, will there be a whole bunch of patients that we never see, that are never referred to us, that could benefit, or?
Well, it's said that in the US 1.6 million people have severe tricuspid regurg, 10,000 get surgery, so huge potential. I think these numbers are non-magic numbers, but we'll probably have to run good studies with good quantification in patients who receive full medical treatment, which is not easy to define in the field of tricuspid.
So how could we identify those patients, Hendrik?
Well, I think it's more easy to identify them now that we have the mitral treatment, because very often tricuspid disease is accompanied by mitral valve disease. And then we start treating the mitral valve, but we see that not every patient takes profit on the tricuspid side. Those will be the first wave of patients I see for such a treatment. But once we have then implemented good technology for this, then we see all the others that might come. And I also think it's a huge number. We just don't see them right now because we have no treatment for them. Right. Exactly. Once we have this, change of things.
Great. Well, thank you both very much for giving this insight in a difficult topic, valve in ring and valve in tricuspid, native tricuspid or tricuspid ring. Thank you very much. This was at EuroPCR 2017. Thank you very much for your attention.